Welcome to today's Expert Explainer. Breast cancer is a diagnosis that will completely alter the lives of millions of people globally this year alone. Today, we're doing a really deep, structured analysis of a milestone review on breast cancer treatment that was published in JAMA. This was authored by Drs. Adrian Wachs and Eric Weiner over at the Dana-Farber Cancer Institute. Our goal today? We're going to translate this dense, highly impactful clinical data into clear, actionable, and structured insights.
Let's just jump right in and anchor ourselves to the sheer scale of this disease. 12%. That is the lifetime risk of breast cancer for women in the United States. To put that number into perspective, more than 250,000 new cases were diagnosed in the U.S. in the year 2017 alone. Worldwide, if we exclude non-melanoma skin cancer, it is literally the most common cancer in women. This single statistic really anchors the profound clinical significance of what we're discussing today. It's exactly why understanding the standard of care is so absolutely vital for all of us.
To make sense of all this, we're going to break things down into 6 clear sections. First, background and clinical significance. Then, the 3 major subtypes: systemic therapy for non-metastatic disease, local therapy approaches, metastatic breast cancer management, and finally, disparities and key conclusions.
Let's start with Section 1, Background and Clinical Significance.
So how a patient actually presents, along with their staging, completely dictates the medical approach. Thanks to the modern era of widespread screening mammography, over half of U.S. breast cancers are diagnosed early on a screening mammogram. And here is a really crucial point. More than 90% of patients present without metastatic disease, meaning the cancer hasn't spread to distant sites. For this vast majority of people, the therapeutic goals are straightforward and absolute. First, strict tumor eradication from the breast and regional lymph nodes. And second, the rigorous prevention of recurrence.
Moving right along to Section 2, the 3 major subtypes.
Breast cancer isn't just one single disease. It's actually categorized based on the presence or the absence of specific molecular markers. First up, we have hormone receptor-positive, or HR-positive, which makes up a massive 70% of all tumors. These tumors express estrogen or progesterone receptors, which basically means their growth pathways are activated by these hormones. Next, about 15 to 20% of tumors are ERB2 positive. You might know this by its older name, HER2. These tumors have an overactive epidermal growth factor receptor. Finally, 15% of tumors lack all 3 of these molecular markers, classifying them as triple negative. This subtype is especially important to watch because it carries a higher risk of early distant relapse in the first 3 to 5 years, and it actually has a slightly lower 5-year survival rate for stage 1 tumors compared to the other subtypes.
All right, Section 3, systemic therapy for non-metastatic disease.
So how do we treat these different subtypes systematically? Well, for that 70% of patients with hormone receptor-positive disease, endocrine therapy is our absolute go-to systemic tool. The mechanism here is honestly brilliant. It directly counteracts that estrogen-promoted tumor growth. The standard therapy is taking a daily oral medication for 5 years. For both pre- and postmenopausal women, tamoxifen is used to competitively inhibit estrogen from binding to the receptor. For postmenopausal women, aromatase inhibitors can be used to actually decrease circulating estrogen levels. And the efficacy? It's undeniable. 5 years of tamoxifen reliably reduces recurrence rates by about 50% in the first 5 years after diagnosis. There's also a really viable switch strategy, taking tamoxifen for 2 to 3 years, then finishing the 5 years with an aromatase inhibitor. This helps minimize the specific toxicities associated with each drug class.
Now, you might be wondering, what is the optimal duration for this therapy? Since HR-positive patients can unfortunately experience recurrence even decades later, trials have directly compared 5 years versus 10 years of extended endocrine therapy.
The data shows that a 10-year course of tamoxifen gives a modest 2.8% absolute improvement in breast cancer mortality. But, and this is a big but, this survival benefit has to be carefully and highly individualized for each patient. Extending the therapy definitely increases the risks of severe toxicities. We're talking about increased endometrial cancer and thromboembolic disease with tamoxifen, and new-onset osteoporosis and bone fractures with aromatase inhibitors. It's a very strict balance of risk versus reward. What about ERBB2 positive tumors? The introduction of targeted therapies here has literally been a game changer. The standard of care now requires a 1-year duration of trastuzumab, which is a targeted antibody combined with chemotherapy. For higher-risk patients, a second targeted antibody called pertuzumab can be added to push that recurrence risk down even further. Now, on the flip side, triple-negative disease lacks these molecular targets, so it relies entirely on cytotoxic chemotherapy. When this chemo is given before surgery, which we call neoadjuvant therapy, achieving a pathologic complete response is huge. If there's no residual tumor left at the time of surgery, that is a highly favorable prognostic biomarker, and it predicts significantly better long-term survival for the patient.
Which brings us to Section 4, Local Therapy Approaches. After looking at those body-wide systemic treatments, we have to talk about local therapy, the direct anatomical eradication of the disease. For breast surgery itself, we've long known that a lumpectomy paired with radiation is totally equivalent to a full mastectomy for survival. But the way axillary lymph node surgery has evolved is really fascinating. Historically, surgeons would do a full axillary lymph node dissection, or ALND, but landmark trials like ACOSOG 011 completely flipped this paradigm on its head. They proved that for select patients who are clinically node negative but end up having 1 or 2 positive nodes found at surgery, a much less invasive sentinel lymph node biopsy gives equivalent survival outcomes to the full dissection. Why is this such a big deal? Because skipping that full dissection literally halves the prevalence of lymphedema, which is a painful chronic arm swelling, dropping it from 23% down to just 11%.
Radiation therapy is basically the other main pillar of local control. Following a lumpectomy, whole breast radiation reliably cuts recurrences, both locoregional and distant, by about half. Interestingly enough, current guidelines actually prefer a hypofractionated schedule now. That means a shorter overall course of slightly higher daily doses. It's just as effective, and it actually improves cosmetic outcomes for the patient. Plus, post-mastectomy radiation provides major survival benefits for patients with positive lymph nodes, and regional nodal radiation has proven to improve disease-free survival in certain high-risk patients.
Let's look at Section 5, Metastatic Breast Cancer Management. For the roughly 6% of patients who initially present with stage 4 disease or who sadly experience a distant recurrence later on, our focus has to shift. In metastatic breast cancer management, the goals transition away from cure and lean heavily toward prolonging life and palliating symptoms. The standard approach here uses a very specific therapeutic algorithm, and there's one key principle you'll see across all subtypes: the critical use of serial single-agent therapies. Multiple randomized trials show us that using single-agent chemotherapy sequentially gives equivalent overall survival to heavy combination chemo, but with way less toxicity and a much better quality of life. As for median survival, it varies a lot, from roughly 1 year for triple-negative all the way up to 5 years for the HR-positive and ERBB2-positive subtypes.
Let's break down that metastatic pathway a bit more. For hormone receptor-positive disease, the strategy integrates targeted CDK4/6 inhibitors along with aromatase inhibitors very early on. This is great because it delays the need for traditional chemotherapy. For ERBB2-positive metastatic disease, the frontline protocols combine those targeted antibodies we mentioned earlier, trastuzumab and pertuzumab, with a taxane chemotherapy. And for triple-negative disease, as you'd probably expect by now, it relies heavily on sequential single-agent chemotherapy. The one exception is if the patient has a specific germline BRCA mutation, which actually opens the door to use targeted PARP inhibitors. The overarching goal every single time is to maximize efficacy, minimize toxicity, and delay broad chemotherapy for as long as possible.
Finally, Section 6, Disparities and Key Conclusions. We need to step back from the molecular pathways for a second and look at some objective, real-world data regarding health disparities. A rigorous analysis of hundreds of thousands of records from the National Cancer Database reveals a really stark reality. Breast cancer mortality is 41% higher in Black Americans compared to white Americans. The data clearly shows this disparity is primarily driven by structural and socioeconomic factors. For instance, Black women were far more likely to be uninsured or on Medicaid, 22.7% compared to just 8.4% of white women. The top contributing factors driving this mortality gap were, in order, insurance status, presenting with larger tumors or higher risk receptor status, having more comorbidities, and differences in actually receiving treatments like surgery or chemo. The data proves, for sure, that lower socioeconomic status directly contributes to poor outcomes.
So, as we wrap up this explainer, we've definitely seen how targeted therapies and surgical de-escalation are drastically improving lives. It's incredible progress. But the data forces us to ask some tough questions. How is the oncology community going to actively eradicate these systemic care and insurance disparities? And at the exact same time, how will we innovate new treatments for those high-risk chemotherapy-resistant patients, like those with triple-negative disease who don't get that complete pathologic response? Science is moving incredibly fast, but ensuring those advancements reach every single patient equitably, that remains our greatest challenge. Thank you so much for joining me on this explainer. Keep analyzing, keep questioning, and I'll see you in the next one.